MEO briefcase entitled Co-Management Strategies in CKD, the Role of the Pharmacist in Counseling Patients. Today's program is supported by an educational grant from Bayer. Again, I'm Dr. Dhiren Patel, an adjunct associate professor of pharmacy practice at the Mass College of Pharmacy and Health Sciences and a clinical pharmacy specialist in Boston, Massachusetts. With me today, I have Dr. Bob Bush, Director of Clinical Research at the Community Endocrine Group, Albany Med Faculty Practice in Albany, New York. Welcome, Dr. Bush.
Thanks, Darren. I appreciate it.
So we'll get right into it. A couple of the things that we want to cover in today's brief case is hit on two main learning objectives. The first of which is we want to spend a little time in describing the pathophysiologic features of CKD, giving rise to renal, CV, and mortality risk in patients with CKD and type 2 diabetes, despite optimized management according to the current standards of care. We know that some of these areas are not as easily explored or easily recollected. And so we'll spend a little bit of time talking about the renal CV and the mortality risks in this patient population. And the second thing that we're going to be focusing on is to better assess the newer agents, specifically the efficacy and the safety of that data in patients with type 2 diabetes and CKD. So the way that we're going to start off, as I mentioned, we're going to do this through a patient case. And so our first patient case is Miss Washington. So Dr. Bush, could you walk us through this patient case and tell us a little bit about this patient?
Sure. So Miss Washington is a 43-year-old Black woman who works at a high school. She's referred by her PCP to endocrinology to optimize her diabetes control. She had a past history of gestational diabetes, and she has hypertension. Her father had an MI and was on dialysis and died at age 62. She's on an ARB with losartan. She's on metformin for her diabetes. And her vitals, as you could see, her pressure's 132/82. She's overweight. Her LDL's 112 with a triglyceride of 115. Her A1C, despite metformin, is 8.5. She has a creatinine of 1 with a GFR of 70 and a urine microalbumin creatinine ratio elevated at 240, normal's under 30. By the way, her foot exam was fine.
Excellent. Thank you, Dr. Bush. And what I want to do is, even before we go into kind of dissecting this patient case, I'm sure many of you have already started thinking about a few things that come to mind, is I want to introduce a quick polling question to see kind of where we are. And so the question here is, given Miss Washington's case and the following options on her formulary, what addition to her medication regimen will address both her uncontrolled blood sugar and her decreased eGFR/elevated UACR? Is it A, finerenone, B, saxagliptin, C, dapagliflozin, D, pioglitazone, or E, I'm not sure. So go ahead and key in your answers. So Dr. Bush, now when we look at this CKD progression heat map, based on what you just described, where does Miss Washington fall? And maybe if you can give us a little bit of color as to why, we use this heat map, because we know in practice, eGFR is something that's routinely checked, but UACR, in many cases, even though we have patient populations that are at risk or even diagnosed with conditions such as diabetes and hypertension, might not always have a UACR on file.
So when you look at someone with kidney disease, you want to classify them. For those of you who know the Framingham risk for heart disease, when you look at family history and smoking and hypertension, and it puts the patient at higher risk. Similarly, this CKD heat map from the Kidogi map shows you two key things. One is the eGFR, which shows you lack of kidney function. The worse the grade, the worse the kidney function, from grade 1, which is over 90, to grade 5, which is dialysis, so a GFR under 15. And on the top part, and horizontal, is the urine albumin creatinine ratio. Should be ordered at least yearly on someone with diabetes, often not ordered, but this shows kidney damage, that a normal urine micral is under 30. That's category A1. A2 is in the middle there, 30 to 300, and A3 is over 300. So if you look to see, and the darker the red, the more likely that patient is going to be on the high-speed train to dialysis, that they're going to end up getting, going to end-stage kidney disease quicker than if you're in the green or yellow or orange. So to start out with, her urine microl was in the 200s, so she's in the yellow zone, and her GFR was 70. So here she is in that yellow zone in the middle.
Excellent. No, that's really helpful. And I think that analogy to the Framingham is a great way to kind of put it, because we want to understand where on the continuum, and in this case, the heat map, where this patient is. And so I alluded to this a little bit regarding some of the drivers of CKD. And I mentioned, diabetes or elevated blood sugars or hypertension. Dr. Bush, there are certain other ones that are also not as well known. Could you spend maybe a little bit of time kind of going through, inflammation, fibrosis, and some of these other drivers that are less known?
So certainly hypertension and diabetes are big drivers of kidney disease, but oxidative stress and inflammation, for example, obesity, which is a high inflammatory state, or someone say who has other kind of general inflammation, that would be a driver of kidney disease, and fibrosis or scarring in the kidney. And many don't know that the hormone, the mineralocorticoid, aldosterone, or mineralocorticoids can lead to inflammation and fibrosis. This has been known since the 1930s, where when they gave mineralocorticoid to lab rats and looked at their kidneys, they had a lot of inflammation and fibrosis in the kidneys. So anything that can block mineralocorticoid would be important to help prevent kidney disease, as well as controlling the blood pressure and how you control the blood pressure, and lowering the blood sugar and how you lower the blood sugar would all be important things in order to benefit the patient.
Excellent. No, that's really helpful. So when we think about current standards of care, we know that the ADA guidelines have some specific language, regarding the strategy to reduce the risk of kidney disease and cardiovascular disease. One of the things that is very novel and innovative in your practice, and I know you've been doing this for many years, is you have a multidisciplinary team that takes care of your patients, and specifically you have pharmacists that are at the center of this. And especially with our audience here today, maybe if you can comment a little bit about maybe just first about the standards of care and what we're supposed to be doing with CKD, and maybe if you can give us an example of how you have pharmacists, helping with this, because there's a lot that needs to be done, and everyone just can't do everything on them by themselves. And so I think if you could give us an example there of how you've embedded pharmacists within your practice, and specifically how you're applying to these standards of care.
So Darren's aware that we've been very spoiled by having the PharmD police around us for the past 20 years. And our pharmacists, our 6-year pharmacy students, go in the room before I do in a patient with diabetes. And what we do is we try to teach them about diabetes over the month, but they could come out managing diabetes better than probably 95% of internists do, because they focus on diabetes the whole month. Mm-hmm. So they will have their little cheat sheet in the beginning, and then it's second nature to them. They know with someone with diabetes, we want to control their sugar well, and diet and exercise, good blood pressure control, appropriate nutrition, lipid management, where's your statin, and smoking cessation. That's for everyone. Now, someone who has CKD, where's the RAS blocker because of the RENAL trial showing that you lowered end-stage kidney disease by 16%, adding losartan. That was the RENAL trial back in 2001. But more recently, we have found that SGLT2 inhibitors in the CREDENCE trial with canagliflozin and the DAPA-CKD trial both showed lowering end-stage renal disease on top of the RAS blocker by adding these drugs. So those would be standards of care. And when I said when we're controlling diabetes, how you control the diabetes would be important. There's also some data with GLP-1s that these may lower proteinuria and may have some renal benefits. Antiplatelet therapy is important, and recently we've learned about mineralocorticoid inhibition to lower that inflammation and fibrosis. So walking in the exam room, they know to ask, where's your ACE or ARB? Where's your statin? The not so much for kidney disease. If they have they still have proteinuria and renal disease, where's your SGLT2? And then the mineralocorticoid inhibitor to lower inflammation and fibrosis. So those would be some of the key things. And as you'll see on a video coming up, the student asks questions before I go in the room. The other key thing is, what over-the-counter meds are they taking? Could it be an NSAID? An NSAID is nephrotoxic. So why are they taking all these good drugs to benefit their kidneys, and they're on a nephrotoxic drug, or going to get an IVP dye in the hospital, or get dehydrated? So they go over some of the key things to protect their kidneys.
That's really helpful, and a great setup that you have there. I think, with RAS and inhibition, I think many of us are kind of aware of the mechanism of action and how renal protective it is through modulating renal blood flow and obviously the tubular function. But could you maybe walk us through some of the newer ones that you mentioned as to what we postulate the renal mechanisms to be in some of those cases? Some obviously now are approved as distinct indications outside of diabetes status, and others are quickly coming in the pike.
Sure. So if you think of a balloon as the kidney or the glomerulus, you want to lower that pressure in the glomerulus. And many of you know that the RAS blocker will dilate the efferent arteriole, or the blood flow away from, or the air coming out of the balloon. So that would be one way to lower the pressure. But an SGLT2, by urinating out sugar, salt, and water, fakes out the kidney. So there's something called tubular glomerular feedback, and the kidney constricts the afferent arteriole. So if you constrict the blood flow in and dilate the blood flow out, it's like a balloon where you less air going in, more air going out. Guess what? The pressure doesn't build up, and that's a way to protect it. Now, the RAS inhibitor does it hemodynamically. The SGLT2 inhibitor does it metabolically. Now, what about the mineralocorticoid antagonist? Recently, one was approved to benefit the kidneys because these drugs will stop inflammation and fibrosis, a different mechanism than the others. So those three classes are approved already to benefit the kidneys in type 2 diabetes. The hope in the future is that GLP-1s might get this benefit as well. We know they lower proteinuria, but we don't have the end-stage renal disease study out yet. It's called the FLOW trial, being done with semaglutide, but the hope would be that also would benefit the kidneys. So the bottom line is we have lots of stuff to do beyond everyone getting good sugar and good blood pressure.
Sure.
Are you on an SGLT2? Are you on a RAS inhibitor? Are you on a mineralocorticoid inhibitor, and potentially a GLP-1 as well?
Yeah, and what's nice from basically what you just described here is that now you can choose drugs that have a complementary mechanism of action, even for the renal protection, the same way that we've been doing it for diabetes for these many years. So that's excellent, and thank you for that. You mentioned, and you ran through the kind of that list that the pharmacists go through, and I want to spend just maybe a little bit of time to kind of bring everyone up to speed of, sometimes it's a good reminder as to why we do what we do. I think I've heard you say this before, and I may have taken this line from you, is that, statins should be in drinking water. Maybe if you could just maybe go through a few of those pivotal trials that cemented, statins and RAS. And I think for the pharmacists in the audience, this is kind of the reason why why they've become, standards of care, or why, we're getting penalized from a metric standpoint, or if you're, dealing with MA plans, HEDIS and STARS, of why they've become part of some of these, quality-based metrics, is because of the evidence behind them. So maybe Dr. Bush, if you could start with statins, and then we'll maybe go into the RAS blockade.
Great. So statins came out in the late 80s, early 90s, but there was no outcome data when statins first came out. And if you're old enough to remember this, you had to do slit lamp exams of the eyes and liver functions every month, and it was a big to-do until statins, where the statins in the drinking water came out for several big studies. The one that we use the most in diabetes is this CARDS study. And this was a study done giving diabetics whose LDL was below 160 to start with, because 160, everyone would have gotten a statin back then. So if it was below 160, you didn't have to give a statin. They gave 10 of atorvastatin versus placebo to patients with diabetes who didn't have heart disease before and didn't have another reason to put them on a statin. Now, 160, you would think now would be sort of, well, why'd they use such a high baseline? But back then, that was the standard of care. And the punchline is it lowered heart attack, stroke, and death, I think, by 37%. Here you see the breakdown of each of the different components of that. And in addition, surprisingly, the atorvastatin also benefited the kidneys by lowering the slope of GFR fall. But the key is, didn't matter what your LDL was, whether it was below 70 to start with or 159, you had major benefit taking the statin. So when our PharmD walks in the room, they're expecting the patient to say they're on a statin. And if not, why not? Were they on 3 statins and had muscle aches, or why aren't they on a statin? And if you're in retail pharmacy, if a patient comes to your pharmacy filling their diabetes scripts, you could probe them and say, where is your cholesterol drug? If they're not on one, empower the patient to go back to their clinician and say, do you think it's appropriate for me to be on a statin? So in the nicest political way possible, you're part of the care team. Don't say your doctor's an idiot not having you on a statin.
Right.
Where's the statin? What dose of statin are you on? Give the patient permission to tell you they're not on a statin, and say they may want to discuss with their caregiver that there's a lot of data that statins lower heart attack, stroke, and death in patients with diabetes.
Excellent, and I appreciate that review there. For the RAS blockade, you mentioned the renal study already. So maybe if you want to just give us, the one line and the takeaway there, that would be helpful as well.
So renal study gave patients with diabetes who had proteinuria or kidney disease, giving them losartan versus placebo. A similar study was done with irbesartan versus placebo, called irbesartan diabetes nephropathy trial. The bottom line is it lowered events by 16%. Well, that's great, but that means 84% still had events. So there's still residual risk, even though you're on an ARB. And it turns out ACEs or ARBs, again, part of the drinking water in diabetics, if they have proteinuria or hypertension, because it has additional renal benefits versus some of the other blood pressure drugs. It lowered proteinuria, it lowered doubling of serum creatinine, and importantly, the overall outcome was 16% lowering. So that became standard of care back in 2001.
No, that's really helpful. And so, the same way I think we've talked about residual risk remaining from a cardiovascular standpoint in some of the approaches that we've used there, what we're hearing here is that we still need that multimodal approach to CKD to, again, further slow that progression down, because we've bent the curve, but there's still that delta or that change where we can still continue to bend it further. And so that's really helpful. So, you mentioned the SGLT2, the GLP-1s a few times now. They've been elevated within the standards of care. We used to have, restrictions around A1C, which have been removed in the past few years. So, what do you do if you have a patient? You talked about some advantages and benefits of both of them. Is it an SGLT2 or a GLP-1? Or in most cases, since patients are on 2 to 3 drugs, do you usually have them both on board? What is your thought process there?
So it's like you have a son and a daughter. Who do you love more? So currently, the standard of care is if you have just atherosclerotic heart disease and don't have heart failure or kidney disease, you can give the GLP-1 because it's tremendous efficacy and weight loss and no hypoglycemia. On the other hand, if you have either renal disease with proteinuria or low GFR or congestive heart failure, then you'd favor the SGLT2. But in reality, if you're in an area where these are affordable to your patient, they usually are on both, because the GLP-1 lowers glucagon, increases insulin in a glucose-dependent way, lowers appetite, and delays stomach emptying. And the SGLT2 makes you urinate out sugar. So they complement one another in what they're doing. And there's actually combined weight loss with both of these. But SGLT2s, when they first came out, people were worried, oh my God, you're putting sugar in the urine, you're going to cause kidney disease. It's quite the opposite, that you're preventing kidney disease. And so this was shown both with canagliflozin in the Credence trial and dapagliflozin in DAPA-CKD, that both of these drugs showed they reduced end-stage renal disease. Credence was studied just in patients with type 2 diabetes. Interestingly, in DAPA, it was studied in type 2 patients and in patients with proteinuria and kidney disease who didn't even have diabetes, and it benefited those patients as well. So the labels are a little bit different, that the Credence canagliflozin label, you have to have a urine microl over 300 and a low GFR. Whereas in the DAPA label, you could have diabetes or no diabetes, and you don't even have to have proteinuria in the label, even though in the study you did, because it lowered events by 39%. So both had very provocative data, not to leave out empagliflozin. They're doing a similar study, but the results aren't out yet.
That's really helpful. And are we there at the same level with the GLP-1s? Because I know we've seen some secondary endpoints in some of the cardiovascular outcomes trials, but we're not there yet just from a CKD standpoint, are we?
No, not yet. So lowering proteinuria is not the same as lowering end-stage renal disease, which is usually dialysis, transplant, or renal death, or GFR dropping by 40 or 50%, depending on the study. So that's what you have to prove to the FDA if you want to say your drug lowers end-stage renal disease. It's not enough to lower proteinuria. Lowering proteinuria is suggestive, but you have to do the full study. So our practice is fortunate enough to be in this FLOW trial with semaglutide versus placebo on top of patients with proteinuria and diabetes, type 2 diabetes, to look at lowering end-stage renal disease. That study won't be out till 2024. But as shown on the slide on the upper part, lots of the cardiovascular trials with GLP-1 have showed renal benefit in the renal composite, but that doesn't count. You have to do a dedicated renal study to show that the drug works to lower end-stage renal disease.
Okay, excellent. And so I know you mentioned you have many pharmacists integrated within your practice over almost 2 decades now. And so we have the pleasure of watching a video from one of your actual interactions. And so I'm going to go ahead and play it so we can all watch it. And then I have some follow-up questions and maybe a reaction from you.
Great. So great. Marina, you had the televisit with Miss Washington. How's she been doing?
She's been doing really well, actually. She's been dieting, exercising, and everything. She's been following her dietary regimen as well.
In terms of the medication she's on, what kind of side effects or tolerance has she had?
Yeah, so just going through her list of her medication. She's starting off with losartan, 50 milligrams every day. She's been tolerating that well. That dose has been increased from last time, which was 25, now it's 50. And she has no dizziness or any other side effects from losartan. Now for metformin, 1,000 milligrams BID, she's tolerating that well as well. There's no diarrhea or any other concerns with that one too. Then she's taking atorvastatin for her cholesterol, 10 milligrams every day. She does not have any myalgia or any other muscle aches or pains. I did notice that her LDL was 112 last time, so maybe we should check that just to see where her LDL is at, because it's not a goal.
So what goal would you like for that?
Because of her history and her family history, I think her goal should be less than 70.
So in general, a starting dose of atorvastatin drops to about 35–40%. So maybe she'll be at goal, but if she's above 70, we could raise her to 20 milligrams so she's tolerating it.
Yes, I think that would be a good plan for her. The other medication she's taking is the paclitaxel, 5 milligrams every day. She's also tolerating that very well. There's no, she didn't mention anything about her yeast infections or any kind of UTI, so she's tolerating that well as well.
Great. So we have some room with DAPA up to 10 if our A1C is high. And if our A1C is above 7, despite that, any other class that you might consider adding?
Yeah, she does have obesity, so I think a GLP agonist would be a reasonable choice for her. It will help her reduce her weight and also help bring down that A1C.
Right, and they have some cardiac benefits with that with their family history. And it does not cause hypoglycemia, just like the metformin or the SGLT2 does.
Yeah, exactly.
Well, that's it. I look forward to seeing her labs. We'll give her a call.
Okay. Thank you, Dr. Bush.
Thanks.
Excellent. So, Dr. Bush, what do we see there? Obviously, we just heard a very rich discussion, but walk us through what that usually looks like, and a few things that we've learned here about our patient.
So if the patient was only on 25 of losartan, that's sort of the little old lady dose. I mean, we use it, but that's being overly cautious. The dose can go up. So you should be comfortable maximizing the ARB in someone with proteinuria who doesn't have hyperkalemia and doesn't have hypotension. So in fact, in most of the studies, you had to be on maximal ARB to be in the study because ARBs have shown benefit already and you want to maximize that. Her metformin was already 1,000 twice a day, but you remember her A1C was in the 8s. So dapagliflozin was started with her at the visit, 5 milligrams. You could give 10, but some people would start 5, see if the patient tolerates it without a yeast infection, a urine infection, and then go up to 10. By the way, dapagliflozin also will lower the blood pressure a little bit, along with her ARB. And atorvastatin was added because it's, as we said, in the drinking water. It didn't matter what her LDL was, but it was 112. So not only was it high, but we would have given it even if her LDL was 80. So, and as you all know, as pharmacists, patients with diabetes are on a lot of meds. And the whole goal that we have is to share with them why each drug is given to them, because you're treating a silent illness. So you want to empower them to know why they're on these drugs. So, you know, they want their A1C down to lower eye, kidney, nerve disease. They want their statin on board to lower heart disease. And here the losartan and the DAPA are benefiting her kidneys. Her urine microalbumin was 320. So it did go up despite the losartan. So she got higher losartan, and dapagliflozin was added as a twofer to lower A1C as a diabetes drug, and threefer, and lower her blood pressure and her weight. And also it would prevent kidney disease.
Excellent. So we're going to actually go right into our next question. So after hearing the follow-up call, what would you recommend for Miss Washington's medication regimen now? Would it be addition of meloxicam, B, addition of finerenone, C, encourage adherence to the therapy as prescribed, D, change the SGLT2 inhibitor to a GLP-1, and E, I am not sure. So go ahead and put in your answers. So Dr. Bush, now if we go back to Miss Washington, you know, now on the CKD progression heat map, where does she lie now?
So here she went from the yellow to orange. Her urine micral increased, and we didn't put down what her next GFR is, but she's heading towards red. And so here's someone who's progressing in front of you, despite being on the losartan. So dapagliflozin was added, but here you want to do everything possible you can to benefit her kidneys, as long as the benefit outweighs the risk for the patient. So here's someone you are treating hemodynamically with the ARB, you're treating metabolically with the SGLT2, and you'd want to even do better if you can to lower inflammation and fibrosis with this multi-pronged approach to benefit the patient.
So no, that's a great point. So I mean, up until recently, we actually didn't have all these tools, right? We only had one tool in our toolbox from 2001, and that was it. And so now, you know, we've taken advantage of an SGLT2 inhibitor. Now you mentioned, you know, we could add on an MRA, but could you maybe just give us a quick overview from the pooled analysis of like where this came from and how this was even, you know, studied?
So these are recent New England Journal studies announced at some of the big European Society of Cardiology meetings, where there are sister studies done with the drug finerenone. Finerenone is a mineralocorticoid inhibitor. Now, many of you are familiar with spironolactone and eplerenone. You also are familiar spironolactone we use to treat hirsute women because it blocks male hormone. So not a great drug for a man who can get impotent or grow breasts. And eplerenone doesn't have the efficacy of spironolactone, but eplerenone has been used, but both of them could cause significant hyperkalemia. So finerenone is called a non-steroidal mineralocorticoid inhibitor. And what they did is they wanted the benefits of a mineralocorticoid inhibitor to stop fibrosis and inflammation without the significant side effect of hyperkalemia or the off-target effects that spironolactone may have. So there were two studies done. Fidelio was a study done to prevent end-stage renal disease in patients with type 2 who had proteinuria, either low amounts of urine albumin with a GFR under 60 or very high amounts of urine albumin, 300 to 5,000, with GFR that went up to 90. The Figaro trial looked at lowering MI, stroke, death, and heart failure in those same patients with a secondary endpoint of preventing end-stage kidney disease. The Fidelio was the primary endpoint was end-stage kidney disease, and the secondary was cardiac. So they pooled this data together and had 13,000 patients in both trials. And this way they had a richer database to analyze the renal benefits of the drug and the cardiac benefits of the drug.
Okay. That's really helpful. And so I think maybe one of the things that I picked up is here in this first patient, you originally had added, the SGLT2 to get that 2-for-1, and now we need that additional renal. And so that's where the finerenone comes in. So let's go back to Miss Washington's initial visit. And if we recall here, we were looking for something with a twofold benefit, right? So we want something for the uncontrolled blood sugar, but we also needed to decrease the eGFR and the elevated UACR. So which option below would make the most sense to add to her medication regimen to address, again, both of the issues? Would it be A, finerenone, B, saxagliptin, C, dapagliflozin, D, pioglitazone, or E, I am not sure?
Am I to answer?
Yes, go right ahead. What do you think?
So even though finerenone is a good drug to prevent kidney disease, it doesn't control blood sugar. So if you wanted a twofer, you give dapagliflozin, which initially the SGLT2s were approved to lower A1C with the other benefit of lowering weight and blood pressure. So you get sort of 3-for-1, a diabetes trifecta. But then when it came out that it prevents congestive heart failure and also prevents end-stage kidney disease in someone with kidney disease, she'd be the poster child who should be on an SGLT2 such as dapagliflozin. Saxagliptin is a reasonable diabetes drug, but doesn't really benefit the kidneys. And pioglitazone is an insulin sensitizer, can put some weight on. We use it on occasion, but it does not have renal benefit. So finerenone has renal benefit, but doesn't benefit the blood sugar. So the better answer here would be dapagliflozin.
Excellent. And let's look at the next question. So that one is, after the follow-up telehealth call, which of the following would you recommend for Miss Washington's medication regimen? So A, addition of meloxicam, B, addition of finerenone, C, encourage adherence to therapy as prescribed, D, change the SGLT2 inhibitor to a GLP-1, or E, I am not sure. So what would the best answer here be?
So the worst answer would be meloxicam, because this is an NSAID, so it would harm the kidneys. So I wouldn't be doing that. Changing the SGLT2 to GLP-1, if you want better glycemic control, you could add the GLP-1 to SGLT2, but in general with diabetes, you add, don't switch if it's a different class of medicine. And even though GLP-1 might help proteinuria, we don't know yet if it will prevent end-stage renal disease. Certainly you want to encourage her to take the med she's on, but assuming she's doing that with the losartan and with the dapagliflozin, you'd add finerenone to this as long as her potassium was under 5, and the plan on rechecking her potassium in a month. And if it stayed under 5, you'd even dose it from 10 to 20 milligrams. If it went to 5, 5.5, you continue the same dose. If it went over 5.5, then you'd stop therapy.
That makes perfect sense. Thank you so much. And so what I want to do here is kind of always put some ways that we can take this knowledge and put it into practice. And so we have a slide here that talks about SMART goals. I think many of you are familiar with them. You use them in practice with your patients to making sure they set realistic goals. So something that's specific, measurable, attainable, relevant, and timely. And so in today's CMEO briefcase, hopefully everyone's got a chance to not only improve the care of their patients for type 2 diabetes and CKD, but you're able to walk away with something that you can, again, turn around and apply it to practice. And so a couple of key things to just reiterate here. I think, Dr. Bush, you've done a great job here kind of talking about the pathophysiology, but specifically explaining that relationship with, increasing renal and CV risk and why we care about some of these other outcomes beyond, just being oriented from a numbers standpoint, so to speak. The other is this MR overactivation that we've seen, which obviously leads to fibrosis and inflammation. And so again, those are things that we want to target. We've not had agents available to us in the past that have been able to address some of these drivers of CKD. And lastly, now we have a lot of different tools. We can do combination approach, multimodal, that are taking advantage of different mechanism of actions through just having your baseline ACEs and ARBs, but now you have the ability to add an SGLT2, GLP-1, and now, finerenone. So again, it's opened up all the different options for us and giving us, again, more tools. So again, I want to thank you for taking the time today. Today's CMEO briefcase is the second in a series of case-based activities. So be sure to check out our other briefcases in the series, which focused on identifying patients at risk of CKD. Both activities can be found in the CMEO Virtual Education Hub at the web address you see on this slide. And I also want to point out here that you can visit cmeoutfitters.com, Virtual Education Hub, where you can get additional clinician and patient education materials. And so again, you can use this in your clinic visits. These are things that you can hand to your patients. And lastly, to everyone who logged in, to receive credit for this activity, all you need to do is just complete the post-test and the evaluation, and you're able to download your certificate. Dr. Bush, thank you again for taking the time and giving us a glimpse into your practice and how you've done an amazing job embedding Pharmacist into your practice. So thank you again.
Thanks, Stuart.